So, good morning, everyone. Thank you for joining. It's a pleasure to have my colleague, Dr. Kassavetis, today. Dr. Kassavetis completed his medical school at the University of Athens in Greece and subsequently moved to the United States, where he earned a Master of Science in Clinical Neurology and a PhD in Neuroscience from the Queen Square Institute of Neurology in London. His doctoral work focused on human motor control using non-invasive brain stimulation, EMG, and EEG. He then moved to the United States for neurology residency at Boston University and fellowship training in movement disorder at the NIH. Dr. Kassavetis' clinical work, is focused on movement disorder. He has expertise in advanced therapy such as DBS and focused ultrasound ablation. His research focuses on using neurophysiological techniques to enhance our understanding of the pathophysiology of movement disorders, with the aim of developing more effective treatments. He has published 60 peer-reviewed articles and serves on the steering committee of the Clinical Neurophysiology Study Group of the International Movement Disorder Society. Dr. Kassavetis joined GW Department of Neurology and Rehabilitation Medicine in 2024, where he is establishing a growing research program in movement disorder. Thank you so much, Panos, for being our presenter today and for all listening.
Yes, thank you so much for inviting me. I'm really honored to be here today, and this is the last Grand Rounds of the year. And I really benefited from the previous Grand Rounds during this year, and I look forward for amazing series for next year. So I'm going to share my screen. So you should be able to see my screen now. And so the title of the talk today is Parkinson's disease at the front line of neurodegeneration. I don't have any relevant disclosures. Today we're going to talk about the epidemiology of Parkinson's disease, about neurodegeneration and pathogenesis, diagnosis, prevention, treatment, and then shortly I'll mention a project that we planned for oxytocin in Parkinson's disease. So Parkinson's was described by James Parkinson in 1817. James Parkinson lived in London, in Hoxton Square. Actually, he was born. This is the building when he was born. This is the same building where he lived and he actually practiced. And he was also a geologist, and he has published about, in geology as well. This is the same building, how it looks today, and this is an area, Shoreditch in London, that I used to visit during my PhD, and it was, for drinks, and it was kind of inspiring drinks to have in Hoxton Square back then. Now, the face of Parkinson's disease, if you Google and try to find a picture of him, this is what you find. But none of those guys is the actual Parkinson's disease that described the shaking palsy, the Parkinson's disease. So we don't actually have a face of Parkinson. We don't have a photo of Parkinson. The first photo ever was taken after his death, a couple of years after his death. So we don't really have a photo of James Parkinson. Now, he described 6 cases in 1817, and back then the threshold for publication was much lower. So actually 3 out of 6 cases was not even his own cases. So case 2, he just met casually at the street. He says the subject of the case, which was next noticed, was casually met with in the street. Case 3 also, the next case was also noticed casually in the street. In case 5, he didn't even talk to the person. He says in another case, the particulars of which could not be obtained, and the gentleman, the lamented subject of which was only seen at a distance. So he just looked at the person and then published the case. But he did a great job really describing what we know nowadays as Parkinson's disease. Right? Back then, he described it as the shaking palsy, and later on, subsequent authors put his name on this disease. So he described several very important elements of the disease. He noticed that it's extremely slow in its progress. he noticed that there is a proneness to trembling in some particular part, sometimes in the head, but most commonly in one of the hands and arms. So this is the tremor. He described that it is necessary to take the utmost care to prevent frequent falls. He said that writing can be affected, and so writing can now be hardly at all accomplished. The propensity to lean forward becomes invisible. And he also described non-motor symptoms. So he says the sleep becomes much disturbed. He described constipation, the bowels, which have been all along torpid, now in most cases demand stimulating medicines of very considerable power. And again, the walking problem, the patient walks now with great difficulty and unable any longer to support himself. So he did very well describing a lot of very important elements of what we know as Parkinson's disease. And actually, I found this interesting that last week, actually, this is where it was sold, an original of the essay of shaking palsy was sold last week by Christie's for $90,000. So we missed on that opportunity. But, more than 200 years later, the burden of the disease remains very significant. So this is a study that was published just less than a month ago, and although the data is from 2021, and shows the disability adjusted life years for conditions affecting the nervous system. And so stroke remains very high, but then you see Alzheimer's disease, diabetes and migraine, autism, and then you see Parkinson's disease. So it's very high on the list. And the change that we've seen from 1990s to 2020s is very significant. So focusing here, this is for Parkinson's disease, the prevalence. This has increased over these 30 years by 273.9%. A significant increase. This is again the percentage change in age-adjusted DALYs. And you can see that we're doing pretty good treating, improving quality of life for all neurological conditions, but there are definitely some conditions that went up, and Parkinson's disease is right here. And the other conditions are really diabetes, right? Diabetic neuropathy, and then neonatal sepsis, cerebral malaria, neonatal jaundice, preterm birth. These are conditions that, really these numbers are driven by countries that they don't have developed health system. But Parkinson's disease is still here. So these are, again, pretty much the same numbers, but showing the increase from 1990s to 2015 for the disability adjusted life years. And you can see, with stroke, we're doing good. We are improving, obviously, for infectious disease, we're doing great, but Parkinson's goes up, as, some other conditions like MS. And it doesn't matter if you come from a wealthy country or high-income country or low-middle-income country. The numbers don't look good either way. So between 2000s to 2019, the deaths caused by Parkinson's disease and DALYs caused by Parkinson's disease, they go up for both the high-income countries and the low, medium, or middle-income countries. So it doesn't really matter if you're rich or not. The numbers are increasing. And the projections don't look good either. So this is the number of PD cases in millions globally. And this is the projections for 2050. And you can see how we expect Parkinson's disease to increase significantly for both males and females. Actually, males are a little bit more affected than females. This is specific to the United States. The projection by 2037, 1.6 million people in the United States will have Parkinson's disease. And how about the cost? So this is a study that shows the total yearly cost of illness of Parkinson's disease. And this is the United States right here. There's another reference, USA here, but this is actually more than 10 years older. So if you remove Singapore, because this data here represents the lifetime cost, not the yearly costs, and if you remove the Germany and Sweden, because this data here represents only subgroups of patients in advanced stages. So if you just count all patients with Parkinson's disease, you can see that the cost, the yearly cost of illness for USA is among the highest. And the projection for the cost in the United States of Parkinson's disease by 2037 is almost $80 billion. Now, this is a small study, data from here, from GW, from our hospital here, done by Dr. Goss. It's actually in preparation right now. And so what she did was she looked in patients with Parkinson's disease that were admitted here at GW University Hospital and control patients, and compared different metrics. So length of stay was significantly longer for patients with Parkinson's disease. The 30-day readmission rate was also significantly higher for patients with Parkinson's disease at 25% compared to 12% for control patients. Delirium was also higher, significantly higher in patients with Parkinson's disease. So these are, some elements that would justify why the cost is very significant. So what I told you so far is neurodegenerative disease burden has increased. It has increased even in high-income countries. And in USA specifically, the total year cost is very, very high. But what is neurodegeneration? So neurodegeneration refers to the progressive dysfunction and death of selective vulnerable neuronal populations, accompanied by accumulation of misfolded and aggregated proteins. And you can have this problem happening in different areas of the body and, of the nervous system. And you have different conditions like Huntington's disease and Alzheimer's disease and Parkinson's or Lou Gehrig's. And neurodegenerative disorders are usually characterized and classified by their protein that tends to accumulate, like beta amyloid, tau proteins, alpha-synuclein, TDP-43. So in the case of Parkinson's disease, alpha-synuclein is the protein that accumulates. And with regards to pathogenesis, there are multiple mechanisms that have been involved. So you have mitochondrial damage, you have lysosomal damage that actually interacts with protein clearance. So the proteins like alpha-synuclein are not cleared, so they tend to aggregate. More aggregation causes more damage to the mitochondria and to the lysosomes that cause even more aggregation. So when when alpha-synuclein aggregates, then forms fibrils and oligomers, and all these all together, they clamp together and they create the Lewy body that leads to neuronal death and eventually the symptoms. So here are two pictures of neurons with Lewy bodies. So this is two Lewy bodies here in one neuron, and this is one Lewy body with alpha-synuclein immunohistochemistry. So the alpha-synuclein monomers aggregate, they create oligomers, fibrils, Lewy bodies that we can find in the brain, but also we can find Lewy bodies elsewhere, including the gut. So the Bragg hypothesis was very influential. It was proposed by Bragg and Bragg. The first author and the last author are, I think it was a couple actually. And this paper suggested that the Lewy body pathology starts in the brainstem and then gradually spreads upwards, causing different symptoms, starting with symptoms from the brainstem, motor symptoms, and then gradually spreading upwards to the cortex, causing cognitive decline and symptoms that we see later in stages of Parkinson's disease. Now, most recently, in 2022, a newer hypothesis came forward by Per Borghammer from Denmark, who suggested that there are two types of Parkinson's disease. It's the brain first Parkinson's disease and the body first Parkinson's disease. So brain first starts mainly in the brain, first in the brain, starts usually in the olfactory bulb, and the amygdala, presents usually with asymmetric Parkinsonism. Patients don't have so much REM sleep behavior disorder or autonomic nervous system problems initially, but then as the disease spreads downwards in the brainstem, they develop those symptoms, and spreads upwards in the cortex, they develop cognitive decline and neuropsychiatric problems. The body first patients with Parkinson's, actually the pathology starts in the gut, and it spreads upwards through the vagus nerve to the brainstem. So this is this subpopulation of patients that start having REM sleep behavior disorder, autonomic symptoms, and as the disease progresses, spreads upwards, it causes symmetric Parkinsonism, and eventually goes to the cortex and causes the neuropsychiatric symptoms. So the late stages look pretty much the same. This hypothesis explains really how things start. And the starting points are the olfactory bulb for brain first and the gut for body first Parkinson's disease. Now, once you have the aggregates of alpha-synuclein in the brain, then you have this spreading that we think that may share mechanisms similar to how prions proteins spread in the brain. And this paper has this good graph that explains multiple mechanisms, how the aggregates spread from neuron to neuron, and as the one neuron dies, then the proteins spread through this mechanism transsynaptically, through the transmembrane, endocytosis or exocytosis, or through exosomes, moves to the next neuron. Then the next neuron starts malfunctioning, creates more aggregates, and dies, and then those aggregates spread to the adjacent neurons, and the process continues on and on and on. Now, Parkinson's disease is not just a brain disease, but a whole body disease, right? So we moved from thinking about Parkinson's disease as just a motor condition to a condition that has non-motor symptoms as well as motor symptoms. And that happened many years ago. And now we're moving from having a disease that is a brain disease to a whole body disease. And that is really justified by the fact that we can find alpha-synuclein aggregates in many body parts, including the skin and the gut and salivary glands and testes and so forth. So this disease affects multiple body organs. And so the symptoms actually represent that process. So you have the motor symptoms, obviously, that are mainly bradykinesia, rigidity, rest tremor, postural instability. But you also have a lot of non-motor symptoms like olfactory loss, sleep dysfunction, autonomic dysfunction, psychiatric disturbances, cognitive impairment. And so, specifically the autonomic dysfunction, you have constipation, urinary problems, erectile dysfunction. Many organs are affected in this in Parkinson's disease. And the kind of the timeline of everything varies from person to person, but we know that before you develop motor symptoms like bradykinesia, rigidity, and tremor, where usually this is when the diagnosis is made at time zero, you may have decades of premotor or prodromal symptoms like constipation, REM sleep behavior disorder, hyposmia, and so forth. So it's a slow condition that starts, affects multiple systems, eventually creates the motor problems that brings the patient to the clinic, and then eventually progresses and affects pretty much the whole body with multiple symptoms. So that's the course of the disease and the pathogenesis of the disease. Now, even going one step before the pathogenesis, the question is, what is the cause of Parkinson's disease? Is it genetic or is it environmental? And this is a huge debate. And I think that probably both genetics and environment play a role for different patients. There are patients that have monogenetic forms of Parkinson's disease, that genetics probably play a more important role. And there are patients that we don't have any genes, and probably environment plays a more important role. So for the genetics, we do have several genes that we have identified that we know that can cause Parkinson's disease and can affect several processes that a lot of times have to do actually with alpha-synuclein. So oligomerization and fibrillation of alpha-synuclein, mitochondrial dysfunction, endosomal lysosomal dysfunction, impaired neurotransmission, neuroinflammation. But also we have from genome-wide association studies, more than 90, actually, I say here 90, but it's now probably more than 100 significant risk genes that increase the risk for Parkinson's disease. Now, the genetic factors account for about 15% of Parkinson's disease, and that's what we see now, and that's actually what was described many years ago by Gowers. So Gowers, a few decades after Parkinson's described Parkinson's disease, he noticed that about 15% of his patients had family history of Parkinson's disease. But what happens with the rest? Rest 80 or 85% of the patients. Is the environment really so significant? And I think it is. I think that actually we're now changing a little bit the way we view the impact of environment in Parkinson's disease. And so this is how everything comes together, and also with the hypothesis of body first, brain first. So this is how it goes. You have some environmental toxins that you can either ingest through food, and then you have the pathology start in the brain, in the gut, and spreads through the vagus nerve up to the midbrain and affects the brain. Or you can actually inhale the toxins and go through the olfactory bulb, through the nerve, straight to the midbrain, and then spread upwards and downwards. And that would be the brain first. In fact, some people think that environment is what caused Parkinson's disease in the first place, and that's when James Parkinson described it. It was not described before, and this is in 1817, right in the middle of the Industrial Revolution, where factories started to work and to have a lot of smoke, a lot of pollution. The air was terrible. In fact, several years later, more than 100 years later, there was this period of time, in London described as the Great Smog. So within 5 days, about 4,000 to 12,000 deaths happened in London, and this actually led people to take some measures, and a few years later, they created the Clean Air Act to regulate the pollution. But there's more than that. There are multiple studies that link Parkinson's disease to environmental factors like pesticides and herbicides, paraquat, rotenone, Agent Orange in the veterans, heavy metals, and solvents. This is a meta-analysis of pesticides risk and pesticides exposure and Parkinson's disease. And although there's a lot of heterogeneity, most of the studies show the positive correlation. This is a map of patients. The top map is Parkinson's disease cases per 100,000 population. And the bottom map is the use of paraquat in 1992. And you can see how these two maps kind of match. It's a very interesting study from Mayo Clinic, Minnesota, where they looked where people lived, where's their house, the proximity to golf courses, and the risk of Parkinson's disease. And they found that if you live less than 5 miles close to a golf course, then your risk of Parkinson's disease is increased. And so the idea is that it's really the pesticides that are used in the golf courses to keep the green perfect that the players are exposed and they develop Parkinson's disease later on. So paraquat is manufactured by this company Syngenta, which is actually owned by the Chinese state, and paraquat has been banned by China and Europe and many other countries, but it's still used in the United States, and these are the imports in millions of pounds over the years. These are two interesting studies about exposure and risk in Parkinson's disease. So this first study looked in 99 twin pairs discordant for Parkinson's disease. So one had Parkinson's disease and the other didn't have Parkinson's disease. And they interviewed them about their lifetime exposure to 6 specific solvents. And they found that specifically exposure to trichloroethylene, the TCE, significantly increased the risk of Parkinson's disease with an odds ratio of 6.1. Now, this is the other study on the right is also very interesting. What they did was that they looked into veterans that served in Camp Lejeune in North Carolina. This was a camp where they had contaminated water, and they compared the rate of Parkinson's disease in that population of veterans to a different population that served in a different camp in California where the water was not contaminated. The main contaminant was also TCE here. And they found that veterans that served in Camp Lejeune had 70% higher risk of Parkinson's disease. In fact, it's interesting that this solvent, the TCE is actually a degreaser and solvent. So it's used in dry cleaning industry. And so in Camp Lejeune, there was a dry cleaner service in the camp that was used for all the uniforms, for all the active duty military personnel, and they disposed the TCE in a non appropriate way, let's say. So the water was contaminated because of that. All right, so we talked about the pathogenesis. Now, how do we diagnose Parkinson's disease? So this is the movement disorder clinical diagnostic criteria. Again, this is 200 years after James Parkinson described Parkinson's disease, and this is what we would call clinically established PD, Parkinsonism, which is defined as bradykinesia, as well as rest tremor or rigidity. And then you need two more of the below. Benefit to levodopa, levodopa-induced dyskinesias, rest tremor, olfactory loss, or positive MIBG scan. And then you put those all together and you try to decide what are the probabilities. So you have on one side, you have the necessary signs, which is Parkinsonism, bradykinesia, tremor, rigidity, or both. And then you have the supportive criteria, as I said, those two, for example, rest tremor or good response to levodopa. But then if you start adding some red flags on the other side, like early falls or early bulbar dysfunction, then you become a little bit more uncertain. So you go from clinically established to clinically probable. Then if you start adding more red flags, like if it's symmetric, for example, that would be unusual for Parkinson's disease. Or if you add exclusion criteria, then you move away from the diagnosis of Parkinson's disease. So there is some uncertainty. There is some, probabilistic thinking that you have to explain to the patients when you diagnose them with Parkinson's disease. We do have some diagnostic tests that we do nowadays. So DAT scan is one, and I'm sure you're familiar with the DAT scan. It's really the presynaptic dopaminergic transporter density in the striatum that is reduced in patients with Parkinson's disease. So the right side would be abnormal, the left side would be normal. This was approved more than 20 years ago, so we use it quite a bit. The sensitivity and specificity are not perfect. And to be honest, from my experience, really it depends on how you interpret the scan, and even the technique can actually sometimes confound the results. So this is a newer kind of under investigation technique that my colleague John Hang Cho here from GW, the biomedical engineer department, is trying to work on, and we're actually developing a ground application to test that in Parkinson's disease. So he's using this new technique with MRI, the oxygen extraction fraction, which is the percentage of oxygen that tissue extracts from the blood. And he can do that through an MRI brain. And some preliminary data that he has before coming to GW, actually, he showed that early stage Parkinson's disease would have increased OEF compared to healthy controls. So OEF increases early in the disease, and then with advanced stage Parkinson's disease, it becomes down, it decreases again. So this is an interesting finding, and he's actually working now to apply for an R01 and have an AIM-3 for patients with Parkinson's disease that we will collaborate on. Now, there are also biomarkers, not imaging, but alpha-synuclein that we can find in different body parts in the CSF. The skin is the most accessible, so we actually do skin biopsies nowadays for diagnosis of Parkinson's disease. C&D Life Sciences is a company led by an MD that has developed a very nice pipeline for this test, and we use it quite a lot. So we do punch biopsies, and we're looking for pathologic phosphorylated alpha-synuclein aggregates in cutaneous, autonomic, and sensory nerve fibers. And this directly reflects synucleinopathy. So it's a robust finding, actually. The problem is that it cannot differentiate between alpha-synucleinopathies very well. So between Parkinson's disease, dementia with Lewy body, and multiple system atrophy, these are all alpha-synucleinopathies, so cannot really differentiate between them with a relatively good sensitivity and specificity. These numbers change over time, actually, because this is a newer test. And as we collect more data, these numbers actually increase. All right, I'll move on to treatment. And let's talk about primary prevention. Now, primary prevention for Parkinson's disease, it's really it's really crazy that I'm talking about primary prevention for Parkinson's disease. Primary prevention is what we all can do right now, or people that don't have Parkinson's disease. What can we do so we don't get Parkinson's disease? And I'm sure when you were in medical school, you didn't have a talk about primary prevention in Parkinson's disease. Now, this is, I put here those two authors, the Ray Dorsey from University of Rochester and Michael Ocon from University of Florida. They recently put out this book, The Parkinson's Plan. They're well published, they're very well respected. Especially Ray Dorsey puts out a lot this idea that Parkinson's disease is predominantly environmental, and it's preventable. So they put out, some ideas about what we all can do to prevent Parkinson's disease, and they have more than this, but I selected just some things that you can do, based on the data that we have so far. So we need to wash the produce, even the organic. Caffeinated coffee actually is good. There is multiple studies that showed negative correlation of caffeinated coffee consumption and Parkinson's disease. So there may be some protective effect. Use water filter. Obviously this goes along with don't really poison yourself with potential toxins in the water. Check your well. Try to avoid heavy metals. Consider air purifier. Obviously, avoid pesticides, insecticides. Dry cleaning is an interesting thing. So this goes back to the TCE toxin that I mentioned earlier. And if you dry clean frequently, they recommend you talk to your dry cleaner, make sure they don't use TCE. If they do, probably it's not a good idea to dry clean in that particular store. And when you golf, they suggest ask the golf course, when they use pesticides and try to avoid those days. And then exercise. Exercise is really important. Exercise works with, through neurotrophic factors and through the dopaminergic system as well. So exercise is very important for primary prevention, most likely. Now, secondary prevention, what do we do when we get, for those people that have Parkinson's disease? So exercise still plays a role here. There are multiple studies that were positive for the effects of exercise in Parkinson's disease. So this is a meta-analysis, but that showed that frequent, moderate, or vigorous physical activity is associated with a 34% reduction in Parkinson's disease. And there are multiple studies that show that. But this is a study that I wanted to, sorry about that, that I wanted you to see that it's actually, this is the first study that showed that exercise may be able to reverse Parkinson's disease. So this is a study that was published last year, done in Yale, where they measure dopamine transporter and neuromelanin concentration in the substantia nigra in Parkinson's disease. Essentially, that's the DAT scan, but they were looking at the substantia nigra. And they did 10 patients. They measured that before and 6 months. Actually, I don't have it here on the slide, but it's 6 months of exercise, and then they measured it afterwards. And they found an increase in most of the patients of the dopamine transporter. Increase is good. Patients that as they progress, they would have decrease of those regions. And the exercise that they used was this regimen here. So 5 minutes workout, 30 minutes of strength, cardio, or power, 15 minutes of boxing, and 10 minutes cool down. But they had to do vigorous exercise, and they had a heart rate goal, which was defined as 80% of their maximum heart rate, maximum was 220 minus their age. So this was an important study, and there are more ongoing studies to see if this is really true. This was a very small study, but created a lot of buzz. This is a plant that I use for my patients when I talk to them, when I diagnose them, and talk to them about what are the next steps. Medications are important, but there's more to medications. It's really a lifestyle that patients with Parkinson's disease have to adopt after diagnosis. They have to exercise, they have to fix their sleep, their mental health, they have to fix their nutrition, they have to remain cognitively engaged and have some cognitive stimulation. Now, I'm not going to talk in detail about the medications. Probably a lot of the medications that we have, a lot of them. None of those are curative. They just act in different systems, and they can help significantly with quality of life and the symptoms. But the problems with the medications is that as the disease progresses, we get this effect where in the early stages, you take the medication and the concentration in the blood goes up and goes down, and then you take the next dose, it goes up and down. And you remain within this blue area, which is the therapeutic window. So this is the honeymoon period where the patients will take the medication 3 times a day, but throughout the day, they will feel good and sustained effect of the medication. Now, as the disease progresses, what happens is that this therapeutic window closes down, so it decreases. And so they have to take the medication multiple times every day. And sometimes the medication would be too much, sometimes it would be too little. The target is very narrow, so it's very hard to hit that target. And this is when the patients develop motor fluctuations. So sometimes they have dyskinesias, sometimes they are off, it's unpredictable, the quality of life is affected very much. If that happens, we have to move on from oral medications to advanced therapies. One of them is deep brain stimulation. And I have specific interest in deep brain stimulation. I can talk about it for a long time, but I have only one slide here to show really that we have moved from thinking about deep brain stimulation as a last resort to a tool that we can use early in the disease. These are the European Movement Disorder Society guidelines. We don't offer DBS. This is DBS of the subthalamic nucleus. Red is we don't offer it in early Parkinson's disease without fluctuations. But if we have fluctuations, even in early Parkinson's, we can still offer deep brain stimulation. And we can offer it when we have refractory tremor that doesn't respond to the medications, even if it's early in the disease. Focused ultrasound ablation therapies is another way to address surgically Parkinson's disease, and we're proud to have a focused ultrasound program here at GW. This is the timeline of the FDA approval. It's more recent therapy. It was firstly approved 2018 for Parkinson's, and just this year it was approved for bilateral treatment. The targets can be different. The thalamus is one target that helps with the tremor specifically, but there's good evidence about the paleothalamic tract helping with more symptoms than just tremor. And then we have infusion therapies in Parkinson's disease, which is essentially levodopa most commonly. 2024, we had the approval of subcutaneous levodopa, and also in the same year, last year, we had approval of the subcutaneous apomorphine pump. These are easy to start, and if they don't work, easy to discontinue with no significant long-term side effects. There's lots of non-motor symptoms. Unfortunately, we don't have specific treatments for the non-motor symptoms altogether. Its non-motor symptom has its own kind of symptomatic treatment. I want to focus here on this last one, the apathy. There's no FDA-approved treatment for apathy, and I'm particularly interested in apathy. So apathy is untreatable, okay? So what is apathy? It's defined as the lack of motivation characterized by diminished goal-oriented behavior and cognition and reduced emotional expression. That can affect significantly patients with Parkinson's disease, their quality of life, but also the quality of life of their caregivers. And it's quite common. So this meta-analysis showed that about 40% of patients with Parkinson's disease, they suffer from apathy. And if you remove patients with depression or cognitive impairment, you still have 22% of patients with Parkinson's disease suffering from apathy. 1 out of 5 patients with Parkinson's disease has apathy, and we have nothing to offer. I mean, it's very, disturbing when you're in clinic, you see the apathy, you diagnose somebody with apathy, and then they ask you, and what are we going to do about it? And you say, I have nothing to offer. There's nothing that I can do about that. But here's where the role of oxytocin comes into play. So intranasal oxytocin we used for apathy in frontotemporal dementia, and it has been used for other conditions, but in frontotemporal dementia, it did show some benefit with no side effects. Although, it was a modest benefit, this may be something that we should look into. Now, looking into preclinical studies about intranasal oxytocin, you can see actually that there's some neuroprotective effects as well, specifically in Parkinson's disease. So in the MPTP-induced Parkinson's disease model and in the rotenone-induced animal model for Parkinson's disease, oxytocin provided some neuroprotection. And we do have experience here. I mean, not me personally, but Vivek Jain and David Mendelovich and others have done actually 2 studies in intranasal oxytocin for sleep apnea here at GW. So we are actually looking to propose to apply for a grant to do this study in Parkinson's disease. This will be a crossover design study where we will use intranasal oxytocin in Parkinson's disease, and we will look into apathy, but we will look into other metrics as well, like motor, sleep, and psychiatric scales, in addition to apathy, anxiety, and depression. So I plan to apply for this grant early next year. Now, there are some genetic therapies that are very promising, and they're only in clinical trials right now. We use viral vectors to deliver genes in different brain regions that are relevant to Parkinson's disease through stereotaxic injections or in the CSF globally. And usually those studies are looking to improve the circuitry dysfunction or degeneration by injecting growth factors. And there was a specific, actually, gene deficit, the GBA1 gene therapy, where it was used in patients that have GBA1 mutation. So homozygous GBA1 mutation would cause Gaucher's disease, that's separate from Parkinson's disease, but heterozygous GBA1 increases the risk for Parkinson's disease. And there's some clinical studies to study that specific population, but there's potential translation to idiopathic Parkinson's disease in general with this gene therapy. And this is pretty much my last slide. So stem cell therapy is also very exciting nowadays, using human pluripotent stem cells to create dopamine neuron precursor cells and then transplant them to the brain. And there are different ways that People are trying to do that with autologous grafts, allogeneic grafts, and so forth. And the stem cell idea is not new. I mean, there has been some work even about 40 years ago where they used fetal mesencephalic tissue transplants for proof of concept. And it's very interesting actually to read those studies because what they did, I was reading about this study done in Queen Square by very prominent people in the field of movement disorders and Parkinson's disease. And what they did was actually they used fetal tissues from abortions and they injected those to patients with Parkinson's disease. So they had to actually plan, consent the mother and plan the abortion and the injection of the stem cells pretty much at the same time. So they would get the fragments of the embryo, and then they would just extract this mesencephalic tissue, process it in some way, and then inject it in the basal ganglia of patients with Parkinson's disease. Within hours, those surgeries, the abortion and the transplant would happen at the same time. There was some ethical, considerations there. And then, in 2000s, there were some setbacks from results that were not really optimal. They were not good outcomes. So the idea of stem cell kind of died in the early 2000s. But then in 2010s, the technology, developed the embryonic stem cells and iPSCs, and more recent years, these are the technologies that are used. And in 2018, there was the first in human trial with iPSC-derived dopaminergic cells. And these trials are ongoing, actually. And the results are very promising. So patients that have these trials, the biomarkers are looking very promising. Now, these are very small trials, and they really use biomarkers so far. They don't use so much clinical outcomes because they want the trials to succeed. Actually, they have a lower threshold. But as those trials are expanding, we're really looking forward to potentially offer that to the patients when it's available. These stem cell therapies are very different from the stem cell therapies that some patients would get going to Mexico or, and pay $10,000 to get, stem cell therapy for Parkinson's disease. Those things don't work. They're very different from what I'm talking here. And I advise the patients usually to be very cautious when they are sold stem cell therapies. So with that, I will thank everyone for their attention. These are my mentors and collaborators, GW and elsewhere. And this is the CME code for today. Thank you so much.
Thank you so much, Dr. Kassavetis. That was great and very informative. We do have a question from the audience here. And can you comment on nicotine use and exposure, and obviously a relationship to Parkinson?
Yeah, so this is a very interesting one. So smoking actually has been positively associated with, or I should say, it has been proposed it's been found to be protective for Parkinson's disease. So patients that were smokers have less rates of Parkinson's disease. And we think that this is related actually to nicotine, not smoking itself. Obviously, smoking is very bad. And, for some time, we were very uncomfortable with that. We didn't know what to do with that result. There was some controversy about that. But then, this result was replicated multiple times. So it's real. So, I cannot tell you exactly how this relationship works, but yes, indeed, this is a true relationship. We don't advise patients to start smoking, obviously, And we don't advise really to start using nicotine at this point. But yeah, that's a very interesting finding indeed.
I'm on mute. I have a question about the apathy that you mentioned. Does it correlate really with the severity of the Parkinson? I might have missed that, or it's just a finding that can be there regardless of the severity of the Parkinson disease or the stage?
I think it does correlate with the stage of Parkinson's disease. Patients that have more advanced Parkinson's disease, they have more symptoms, they have more apathy. It does correlate with other psychiatric problems, like, I mentioned cognitive decline or, depression and cognitive decline. I think also, apathy is a symptom that probably relates to the cortex. So if you think about how the disease spreads, um, the areas that are affected later in the disease are more relevant to apathy itself. So that would make sense as well. Um, so yeah, I think that does correlate. But 40% is a big percentage, for the patients, right? It's a big population that suffers from that problem.
Absolutely. Don't have more questions in the chat box. Please, if you have any questions, we still have a couple of minutes. You can put them in the Q&A section. And the CME code is posted on the last slide. So let us know if you have any trouble with that.
So yeah, I'll keep you posted about the apathy trial if
No, that's very interesting.
you want
Absolutely.
that.
Absolutely. We have one more question. Could you comment on your personal practice experience? What's the survival length years of your patients with Parkinson disorder?
So with Parkinson's disease, we don't really see a situation where lifespan is decreased. So the lifespan of patients with Parkinson's disease should be the same as the general population. We say that people don't die from Parkinson's disease; they die with Parkinson's disease. So in general, patients would die from the same reasons that people of their age, the same age, would die from. Um, Now, patients that do have advanced Parkinson's disease, sometimes we see deaths related to their symptoms like falls or pneumonia. This would be the two main causes. But in general, in the population and in my practice, I don't see that patients die early. So in fact, this is very different from other neurodegenerative diseases. It's not like ALS, for example. When I first diagnosed a patient with Parkinson's disease, it's not a death sentence. We have a lot of things we can offer to improve the quality of life, and they can still live many years after the diagnosis. And so we need to improve their quality of life because they have a lot of life in front of them.
We have a few more questions. So has early DBS implantation have any neuroprotection effects?
So we don't know that, but this is under investigation. So the early STEAM trial was done several years ago. We moved the DBS earlier in the disease, about 4 years after diagnosis. I think in the early STEAM trial, the average was 7 years after diagnosis, and the earliest patient was about 4 years after diagnosis. But then there is some hypothesis that DBS can be neuroprotective. So in Vanderbilt, they have a trial that they are looking to see to have patients even earlier than that. So within the first 3 years of diagnosis, implant patients with Parkinson's disease. And they, they really feel very strongly that DBS can change the course of the disease. But that's a hypothesis. It remains to be proven, but yeah, some people feel strongly about it.
Are there any gene targeting approach to prevent dopamine cell death early on the substantia nigra?
So for cell death, that would be really the neurotrophic factors that the stem cells, or yeah, that's the kind of the gene therapy that I mentioned here. So the growth factors, this is where people would really inject, with the adenovirus associated vectors. And so GDNF and RTN, these are the growth factors that they would use to prevent cell death.
We have one more question from a non-neurologist, and thank you for attending. So basically, the question is, does delay in initiating treatment for Parkinson disease affect long-term course symptoms, progression, and other factors?
No, we don't know that any of the therapies that we offer now, the oral medications, has any effect on the course of the disease. We don't think so. So starting the medication or not starting the medication would not really make a change on the course of the disease. The only thing that could potentially change the course of the disease is exercise. So we really advise for exercise immediately after diagnosis, even before diagnosis, as I mentioned, because that's probably the only thing that can change the course of the disease. And then we have the genetic therapies and the stem cells that are only clinical trials. We don't offer those practically, in the clinic.
Well, thank you so much. That was our last. Well, there's one more question. We'll take this one, and then it's already 9:01. So the last question is there any data that Eastern USA has more Parkinson's disease incidence than the west half of the United States?
I don't know that. I don't know that. I think that this was the map that I showed was mostly biased towards the east. But I'm not sure that, this general statement that East has more than the West. I cannot recall data specifically to answer that question. Sorry about that.
Well, thank you again for the great talk, and um, that was excellent. And thank you all for attending. Like Dr. Kassavetis mentioned, this is our last grand round for the year. So we will restart on January 6th with our new series. And happy holidays, everyone. Thank you so much.
Thank you. Bye-bye.
Bye.